first two children who had agenesis of the corpus callosum were recruited from Australia. And they were two boys who had agenesis of the corpus callosum. And then they were in a study to find the underlying genetic cause of the agenesis, and that's how we found the CLCN4 variant. So we do know that it is a recognized cause. And for those of you that don't know, because that's a lot of Latin words, the corpus callosum is like a little highway that connects the two halves of our brain. And in some people, that can be a bit smaller if they have CLCN4, and in other people, it can be missing altogether. And what we think that affects is some of our ability to be coordinated in our movement between both parts of our brain and therefore both parts of our body. So we don't say that it's necessary to do neuroimaging on everyone, but if your child has neurological symptoms, so symptoms to do with their movement control or seizures or any worries like that, we do suggest it's a good idea to have a brain scan. And when we do the brain scan, we have seen a small number of individuals who have slight differences with the brain, and the most common thing is this change in the corpus callosum. But in terms of actual figures, we did have that in our big study. I think it's about 25% have some changes in the brain, and the most common feature is agenesis of the corpus callosum, but overall it would be less than 10%. So yes, it is a recognized cause, and we do actually have a scientist who's now moved from Australia to the US that's particularly interested in that. So if people wanted to reach out to me, I could connect you up. And there you go, Jenna says that they found first that the child had agenesis of the corpus callosum, and then they did genetic testing. So the same story as in that Australian family. And actually, there are people just walking around in the general population that have agenesis of the corpus callosum, and you would only know if you were doing very specific tasks. So our brains are very adaptable, and we find ways of getting around these changes. No, absolutely not. And that's a question I get asked all the time. We're humans and we need answers and we need stories and we need to understand why something happened. So many times our children with genetic conditions have difficult births. And that often is, we think, because the baby is just the birth is harder for a baby with a brain difference or a neurodevelopmental condition, not the other way around. So we're starting to now understand that many in the past, we said cerebral palsy was always caused by problems around birth. And now we're realizing that a high number of children with cerebral palsy, they actually always had a genetic condition. And it was that caused the changes with their learning and their development and their muscle tone, not the birth. And so the reason I can say that with confidence is because we know for a de novo change, that's in every cell of the body, and that has to happen very, very early. So it's usually at that stage when the egg and the sperm are coming together, or it's a change within a little pocket of eggs or change within a little pocket of sperm. And how I explain this to my families in Australia, I might have to change my analogy. So in Australia, we have in Sydney, I live in Sydney, the biggest structure is the Sydney Harbour Bridge. So let's maybe call that the Eiffel Tower or the Statue of Liberty. Like think of a big thing in wherever you're living. And if you think of, an old-fashioned like a book, I'm trying to find a book. I do have books. Here we are. Here's a book on genetics. So if you have a book like this and you open this up and each one, oh, I've got my blur on, which doesn't help. Let me take my blur off. Okay, all right, you can see the mess behind me. So in this book, and we think about every single letter in this book, and then this is one book, and then think of piling those up to the top of that high building or statue in your city. That's like our DNA code. So it's thousands and thousands and thousands of letters, little chemical bases that make up our DNA code. And when a baby's being made, they take half of the information from mum, half of the genetic information from mum, and half of the genetic information from dad. And then it has to come together to make a baby. So it's like we were photocopying all of this information and then putting it together. And it's really easy. You know, if you photocopy lots and lots of things, you make a little change. You might photocopy a page twice, or you might skip a page. And it's the same for our bodies. So that's how we get new genetic changes every time a baby is made. And it's nothing that you did, and it's nothing that you didn't do. And it's really important for us mums, especially. We always blame ourselves. We always think, what was it that I did? It was because I painted that room and maybe the paint fumes. You know, just you have to let those things aside. It's nothing you did or you didn't do. It just happens by chance. And if it didn't happen, we'd all be identical and we'll have, you know, gone away as a species long ago. That genetic variation is what keeps us going. What I might do, oh, let's see if I can share my screen and I'll show you. I wanted to show people. So this is the article that Vera and Michael and I wrote, which is the most up-to-date big article. Am I sharing the right screen? Is that like a medical article?
Yes, yes.
And this is very dense, yeah. So this is lots of information, but it's written in very scientific words. And in that one, we found, looking through the databases, that there were 90 variants in 90 families. But we know that number is now even higher than that. And I think you were saying, Rebecca, that even in your Facebook group, which won't be every individual, you've got what, 120 families?
We think between 160 to 190.
Yeah.
Yeah.
So the issue is that we as clinicians and scientists only know about a family if a doctor reaches out to us or a family reaches out to us, or if the laboratory that writes the reports puts that variant on an open access database that we can all see. And so what that means is right at the start, the first families that were finding a change in the gene, we usually knew about them because it was so new, the clinicians were wondering, oh, what does this mean? And they reached out to us. But now, especially if, you know, we've just seen in the chat, so many of you have children with the same variant, and I can almost guarantee that your doctor won't have reached out to us and they won't have put it in a database because they'll say, oh, well, this clearly is the answer because we've seen it before. So it's a really inaccurate way of actually knowing how many people there are. And it's good at the start, but after that, actually, these connections through Facebook groups become much more accurate. And then if you think about, did you find the Facebook in the first week after a child's diagnosis? Many of you, it would have taken a journey. And so there'll be many families out there who have a diagnosis and won't have connected yet with a Facebook group. The other thing is we have to think about the ages of people. So most of you, your children are quite young. And the reason for that is we still don't tend to offer genetic testing to adults with learning difficulties. So in Australia, actually, the government only funds exome sequencing, which is the most important way of finding the change for children under the age of 10. Okay, it's not the case in other countries. I know they have higher ages, but still, that's mainly how we think as doctors. We think it's important to try and find a genetic cause for young children, and we kind of forget about older individuals. So there will be many older individuals walking around with CLCN4 who will have never had genetic testing. And why that's also important is it gives us an unfair idea of the range of how CLCN4 affects people. Because those people where it affects them very lightly, they're unlikely to see a doctor, they're unlikely to have genetic testing. So we tend to get a picture on the families where the child has most issues. So that's a kind of an unfair bias as well. So it's a long answer to a short question. We don't know is the answer. I would be suspicious that there would be actually thousands of people around the world with CLCN4. And hopefully through better connection and better access to testing. And if you think about it, genetic testing is only available maybe in about a fifth of the countries around the world. You know, if you look at that map, there's so many individuals in low and middle income countries that don't even have access to testing.
Thank
And
you,
so
Emma.
my plug therefore is please connect with Simon's Searchlight, because if we know we can't rely anymore on doctors, we need to rely on you families. And the information that you provide to Simon's Searchlight is so critical. Whenever we've done a study, it's a one-off snapshot. It's a clinician writing to us and giving information, and for Simon at one point in time. But what we really need to develop therapies is that information over time. It's called a natural history. And you can see with Simon's Searchlight, they can ask you every year to fill in a form. And I know it feels like, oh, it's one more thing in my life, and I've got so many forms to fill in, and gee, but it's so critical for getting that information that means we can help answer your questions better. Whole area of my research I haven't talked about today, but we do have a project called Gene Equal, which is actually working with people with genetic conditions and asking them what their questions are about the genetic condition and putting together information that's easy to read and understand. So, as far as we know, actually, there are lots of women with CLCN4 variants who have had children. So we know that there seems to be no common reason why someone couldn't have children. So if that's their choice and they would like to have children and that they feel they've got the supports and the resources to have children, there are many wonderful mums out there who have CLCN4. So for a woman, she's got 2 copies of the CLCN4 gene, and one will have the genetic change. And all of her information in her eggs is separated. So half of her eggs will have a typical working copy of the gene, and half will have that genetic change. So what that means is every time if she was going to have a baby naturally and naturally conceive, it's a 1 in 2 chance if the baby gets a copy of the gene that's the working copy or the copy with the CLCN4 change. And then it's a 1 in 4 chance, depending on whether the baby gets an X or a Y from the dad, whether it's a boy or a girl. And so working through that maths, what that means is that 1 out of 4 pregnancies will be a boy with a CLCN4 gene change. And we know that for boys, usually they're more affected. 1 out of 4 will be a girl with a CLCN4 change, and that girl can be very variably affected. And then a half of the time, the child will not inherit the genetic change, and they would have no increased chance of CLCN4 or its complications. So if you use IVF, essentially you're just getting a little step ahead. So you get the eggs from the women, the sperm from the man, they put them together in a little petri dish, and then they check the genetics. And they would check for the CLCN4 change, and they would check for the gender. And they would aim to only put a tiny embryo to start a pregnancy, and that embryo would have the working copy of the CLCN4 gene. So that means that the baby would not have the condition, and the baby would also, and they grow up, have no increased chance of having children with the condition. So it is an option for women and for men with a genetic condition when they would prefer not to have a child with the same condition, then IVF can be an option. And in different countries, there's more or less funding to help support. In Australia, for example, you would get support from the government now to have IVF and that genetic screening, but I know it's not the case in all countries. For that, that's like a very brief overview. I would normally take about an hour to explain that. And the person that you need to see to have that conversation is called a genetic counselor. And genetic counselors should be able to give that information in a way that is understandable for your daughter so that they can make decisions about that with their partner. We do have information from those snapshot that we've done so far. So what we know, for example, is that this is a condition that is a kind of, I explain it like it's a what you see is what you get condition. It's a condition that we know it impacts the neurological system mainly, and that can impact learning and development. However, you can see from all the chat that children still learn. They just go at their own rate, and that can be hard to predict at the start, but with supports, people can progress and learn new things. When we wrote our very first paper, we were worried that some of the individuals might have lost their skills as they got older. But it was very hard because these were often very old individuals who didn't have access to the therapies that our children now have. And in particular, often had seizures that were very poorly controlled because we don't have the epilepsy treatments that we now have. So overall, now we're much more positive that we think that children will continue to grow and develop. But it is really important that we get on top of seizures and that we treat them as carefully as possible. We make sure sleep is happening well. And really importantly, I think one thing we do see is that in older individuals, they can have mental health conditions, such as depression, that is not recognized. And if you have depression or bipolar disorder or a form of psychosis, then you can lose your skills during that mental health episode. And I know we have colleagues in here, and I won't pretend that I'm a psychiatrist, but my understanding is therefore it's really important if you see a change and if your child is losing some skills or things that they don't do, that's like an emergency. See your doctor and get referred to a psychiatrist for a full assessment along with a neurological assessment, because we shouldn't see that happening. But to be completely honest, and this is why I feel like got shares in Simon Searchlight. I don't, and there's no money in Simon Searchlight, is if you can be part of that registry, it means we can collect that information accurately over time. And honestly, that's the only way that I, hand on my heart, can give you the real answer to that, is if we have that data over time. And that's how we as a community, although it seems a very small thing, is the biggest thing we could do to gather that information. And as you can see, what's so great about Simon Searchlight is they will give us back, as a community, the information so we can learn alongside. And if something new comes up, like today I'm hearing pica and precocious puberty and maybe, inflammatory bowel disease. These are all things that we haven't really thought about before for CLCN4. And we get these insights from hearing from you, and then we can do the research about that.
Research, I think, should go in different directions. Regarding diagnostics, I think we should continue to study novel upcoming variants to find out if they are causative or not. But then, of course, research has to go also further. We have to, for example, to understand the role and how the dysfunction of CLC4 protein affects the organ, the brain. I think animal models and induced pluripotent stem cells can be very valuable models, as Emma also mentioned, to find out what is the physiology and what is the pathophysiology of these variants. And then finally, of course, for therapy, if we would like to have therapy, of course, the most promising avenue is likely a gene therapy, because somehow independent of the protein because we act on a level before the protein is actually working. However, also pharmacological approaches in principle can be tried, and for pharmacological approaches it depends very much on the outcome of variants. For example, if we have loss of function variants, a pharmacological agent should improve functionality. But then there are also like this toxic gain of function variants, and for these variants, an inhibitor of CLC4 function could actually be more important than an activator. And however, this is a long way also, and it's very costly to develop pharmacological treatments. But as I said, we have to do research in many different directions. And then finally, still a very little understood aspect is this novel interaction with the proteins TMEM9 and TMEM9B, and there we still have to understand the biology and the regulation of this interaction, for example, by phosphorylation or by other mechanisms that we still don't know. We still know very little about. I mean, that's somehow what I've been talking about. The first thing to do is really to try to find out if this variant of unknown significance, is it related to the phenotypes I see in my child. And one possibility is to do functional measurements, as we do in our group, or biochemical measurements. And I think this is the first thing to do, and try to contact through CLCN4. We are very open to study any novel variants, and we can be and the communication of these variants, and then putting us in contact also with the doctors who are in charge of these patients is would be very useful for us.
So now we're going to move on to some questions for Caroline Vermeulen, who's a child and adolescent psychiatrist. And you probably remember her from last year, and she's very kindly agreed to join again this year to answer some questions. So the first question is coming from Ilaria from Italy. And her question is, how should we manage puberty and development in our children? What impact could it have? And then she explains that they had to give Isabella injections to block her development because otherwise she would have developed by the age of 10. She had been very agitated in recent months, but now she seems to be doing a little bit better.
Well, in the first place, thank you for having me. I'm not allowed, according to the Dutch law, to give individual advice, but I can give some general psychiatric advice. And in case of puberty, we should realize that this is a developmental phase of the brain, and all existing problems may worsen during puberty. We know that from general population as well, but that's also the case for genetic neurodevelopmental disabilities like CLCN4. So what to do? I think you should definitely seek help when your child stops developing. And in other cases, it can be helpful to be patient, at least for a few weeks, and to look really after yourself because you're having a lot to deal with. And during this time, you can look for optimization of sleep and food intake. Just look for a medical cause underlying, other problems that may occur, like sensory overstimulation, because the brain is developing. So sensory inputs can be a bit differently processed during puberty. So all kind of these things may help. But when it does feel for you as a parent that it's not okay, then please look out for help. Yes. I suppose this question is about challenging behaviors. It doesn't say in the question, but I think it is. And we should realize that some of the therapies that are evidence-based, so research has proved that their work, are not checked in children with CLCN4 or other genetic developmental disabilities. But in general, applied behavioral analysis therapies, ABA therapies, are evidence-based for all kind of challenging behavior. And from my clinical experience, I have seen good results of psychomotor therapy as well as music therapy. This is not evidence-based, so this is my experience from daily practice. And indications for these kind of therapies are, for example, improvement of emotion regulation or training of alternative behavior in case of meltdowns and things like that. And often physical activity with repetitive movements may help for emotion regulation, but also to other problems. And music, like for example, drumming is quite popular at my outpatient clinic, or playing, I think you call it a wind instrument, like saxophone or something. May help to for the emotion regulation as well, but also for improvement of depressive moods. So these are some examples. I can talk for hours about it, but I hope this is for this time enough for this question. That's a very important one. I'm very happy that someone brought this up. I think within your family, it's important to visualize that every family member has its strengths and its weaknesses, and that we should be a team and help each other with these shortcomings and stimulate the things that are the strengths. And another thing that is very important for SIPs is to set up SIP meetings with discussion points like, what do I like most about my brother or sister, but also which problems am I facing, and I am not facing them alone. I was quite impressed. Two times, sorry, I'm not an English person, so I do have problems to translate, but I attend 2 sibling meetings in other syndromes, and I was really impressed about all the solutions they came up for each other with, like, oh, I handle it this way, maybe you can try that also. And I think it's most important that they feel the support from other, for example, teenagers that are facing the same problems. And digital meetings can be very helpful also, so over countries. But sometimes language can be a problem. Well, I think we can't, to be honestly. We cannot clearly separate these. And I think the registration like Simon Searchlight can be really helpful to learn more about the natural cause of the disorder. But still, when it's not into the disorder, it still can happen, like anxiety or obsessive compulsive disorder. And it's always a combination of factors. A bit of your temperament, a bit of the environment, and a bit of the disorder, I guess. So it's not possible to separate them. I want to add that it's very important to enhance the ability to communicate. So involve a speech therapist, because a lot of emotion regulation problems are a way of saying, I do have a problem, please understand me. So to enhance communication is really important. And another thing that is really important is to prevent over and understimulation. Overstimulation, I mean too much sensory input, and understimulation is too less. And another thing which might help for the ones who can have a good vision is to visualize the day or a part of a day. So that's a bit of structure and routine coming up that will help as well. And it's important to visualize it. And maybe that was the last question for me, but to help parents, I made a roadmap. I will shortly share it with you, but Rebecca will share it, I think, along the participants of this meeting.
Yeah, let me share it.
I'm trying to share my screen.
I'll send this via email to everyone as well after the meeting.
Okay. So I think there are 5 important steps. Can you see the slides?
Yeah, we can see it.
Thank you. So what is the most important thing to do at first is to rule out the physical cause, because there are over 100 of physical causes that may cause behavioral problems. For example, ear infections may cause head banging, bowel problems like constipation may cause temper tantrums, regurgitation may cause sleep problems and inattentiveness during the day. So that's the first step you always have to do. Never ever skip this one. The second step is to find out whether the behavior is appropriate for the stage of development. I hope I will speak it okay. Mysia also mentioned the Vineland scale. This is one of the scales you can use to find out what is the developmental age of your child. And for example, when your child is about 8 years of age, but he or she functions like a 2 years old, then it's normal to have temper tantrums. 2 years olds need to have temper tantrums. So then it's in the developmental part, and then you should look for pedagogical support. The third step is to find out whether it disappears during weekends or holidays. And when it disappears or is less intense, then you should think about overstimulation or asking too much of your child. And that's an important thing to look into with a specialized physiotherapist or occupational therapist to find out about the sensory processing. The fourth step is to make sure the biorhythm is optimal. So sleep is at best, well, it can't be at best all days, but overall it's quite good, and optimize fluid and food intake. And when all these steps did not give a solution for the behavioral problems, that's the point to find a psychologist or a specialized psychiatrist for looking further into the behavior. And Emma just mentioned alarming symptoms. I also make a slide about that, not to scare you, but just to inform you in which cases you should definitely look for a psychiatrist. And these include no fluid intake or food intake for over 24 hours, a sudden loss of functions, and these can be all kinds of functions, motor functions, communication skills, social skills, for over 38 hours, which are not attributable to a physical disease, and severely disorganized or agitated behavior for over 1 or 2 weeks. And this is often combined with severe sleep disorders. What you should do is find a medical doctor to rule out a physical cause, and if ruled out, request for a referral to a psychiatrist, because these severe symptoms may warrant ruling out serious psychiatric conditions like catatonia, psychosis, or depression. So not to scare you, but just to give you some clues when to wait or when to not wait. Thank you for having me.
Thank you. That's super helpful roadmap. And like I said, I'll make sure to send this to everyone after the meeting so you can use it as a resource. Thank you again so much for joining and for answering all the questions.
You're welcome.
So when we were looking for a name for the charity, we consulted a few people with experience in the field of charitable organizations. And the advice we got was that, look, there are a lot of charities out there where competing for the same pots of money very often, and your name has to be very clear in terms of what your goal is. You know, are we a support organization? Are we a scientific organization? I mean, what what do we want our donors to donate towards. So with the word cure, we thought it was very clear. And we also painted the idea of the urgency and the importance of the condition. And yes, we do get the questions about, like, my child, I don't see my child as needing a cure. My child is just different. And I feel the same way about Daphne. But I also see that there are ways in which she suffers physically and socially. And also with the other families, some families have very medical children. And in that way, that bit we would like a cure for. Yeah, I don't know if you want to add anything.
No, I think you really summed it up well. I think we very much want this organization to make a difference. And one of the other questions that came up in the chat, I'm not sure if everyone had a chance to see it, but it was a good question. It was really, if I paraphrase it, it was, is the scientific research that the charity is funding, is the objective to help the children today, or is it only going to help the children in future? I think the answer is we'd like to help both groups. And there are a number of examples now of gene therapy and interventions. One particular, which we put into the chat, which is a gene therapy study looking at a condition called Angelman's disease, which in some ways has some similar phenotypes to CLCM4, although it's caused by a different gene. But in this case, the children struggle with communication and a number of other issues, and older children, some of whom were teenagers, experienced big improvements in their communication skills on a phase 2 study. I think they're running larger studies now to get more conclusive evidence back. So, I mean, I think there's enough information out there to suggest that even later stage interventions can really make a difference for our children. Emma, would you like to add anything to that?
No, completely. Other than I'm quite linked to the Angelman community here in Australia. We just had our big scientific conference, and 100% echoing that. And it is a question that, so for the Angelman syndrome community, it's much more established. It's a diagnosis that could be made by looking at children, so there's some features that meant that there were many people who are in their 30s and their 40s. So it's a really big community. And we had the American Foundation come and talk to us, including their sort of scientific lead, who's quite open about her daughter has been on trials and things, and a very honest reflection. It's not that a child who's received, so they're mainly the ones that are forging ahead are called antisense oligonucleotide therapies, which was one of the ones that Marlene talked about. And one of the for me as a clinician, the kind of nice things about ASO is it's not a one thing and then you never know what's going to happen in the future. You have to give it and give it and give it. So it's an opportunity to see if it's making a difference. And definitely that focus on quality of life is what we're seeing. So it's changes that are affecting how children communicate. For one family, it was, well, for the first time, my child could sit down still at a mealtime and enjoy a meal together as a family. So, it's not that this child no longer has any differences in their learning, or it takes away their nature or their character in any way, but things that were really difficult, and often for me, seizures is a big focus of my research. For another condition called Dravet syndrome, the ASO therapies are really, really helping. So these were seizures where kids were in and out of hospital, and you can just see on a seizure chart, their seizures are so much better controlled. So I think there's so much, in the past, I've been in genetics for about 20 years. When we started, if someone had said, is there a therapy? And so no, well, it's in a genetic change, so no. And now we're being challenged by that. But it also can, I think, mean that we sort of put more pressure on ourselves because we see it happening in a few genetic conditions. And I also don't want to take away that for the ASOs and things like that, I often find what families say is it helps the therapies work a bit better as well. So don't think that therapies aren't important. The physiotherapy, the psychotherapy, the treatment for medications, these are all absolutely critical. We just hope that one day we'll be able to add on to those with these more targeted treatments. So also don't lose hope that there's nothing that can be done right now. There's so much that can be done right now. And as you can hear, hopefully through the chat, part of that is just finding the right team. So it's finding a doctor or a therapist that's willing to say, I've never heard of this condition, but let me read up about it, or let me find out, and let me listen to you, and let's work as a team together to really address the main issues for your child. So I think it's important. This is happening in the background. It's absolutely critically important. It won't be for everyone. Some people will decide, actually, my child's quality of life is great, and I don't want to be part of this. For other people, their quality of life, they could see it would make a huge difference. But if we don't do the research, and so much of that is that data collection, that clinical data collection, then we won't have those opportunities. Is that fair, Peter and Gina?
Initially, we thought with especially these neurodevelopmental disorders that there's like this small window of opportunity very early on in life. And if you don't hit that, then there's nothing much that can be done anymore. And especially with like Angelman syndrome, but also other neurodevelopmental disorders, we now see that we don't call it a window of opportunity anymore in that sense, but we say that there is just some room for improvement. It might be that some type of the symptoms, they can't be targeted anymore, but it might be that other aspects of the disorders, they're still very variable, and we have this what we call plasticity in the brain, so the brain can still learn later on. So if you can give them a little bit of a push with a treatment and the patients are eager to learn, that can still help improving. So I would say we don't know for every disease, but I wouldn't give up hope that this is indeed possible.
Thank you, Merlin. Yeah, there were another 2 questions, but those have been kind of answered already, I think, with the discussion that's been going on. There's no more questions in the list, so if anyone that's joining live wants to unmute themselves and ask a question, then please go ahead. Otherwise, we'll probably move on to the breakout rooms. Does anyone want to have any questions? Okay, sounds like there's no more questions for today. So before we move to the next and final part of the meeting, I just want to thank everyone for joining and for answering all the questions. It's been a really wonderful meeting. And yes, thank you again.